talk about Childhood Cancer Day. Father, protect each and every cancer survivor out there. Give them good health. Cover them with the blood of Jesus Christ, oh Lord. And it is in your mighty name we do pray and believe.
And everybody said, amen. I will say that on behalf of everybody. I can see you all mouthing amen. Thank you very much, Moses, for that. Important to remember that. So we'll carry on with the conversation. Again, please feel free to just keep on dropping the comments in the Q&A box, in the chat box, and we will be happy to pose that to our panelists a little later on. So let me introduce you to who we have today, who's speaking to us. Of course, we heard from Patrick, who's on the board of NCDAC. Thank you very much for setting the stage for the conversation today. Moses, once again, thank you very much for the prayer. On our panel today, we've got Dr. Deborah Omido. Dr. Deborah Omido is a pediatric hematologist, and she's working and oncologist based at the Kisi Teaching and Referral Hospital. Dr. Deborah, thank you very much for joining us today. We also have Professor Ruth Ndwati, who's a professor of pediatrics at the School of Medicine at the University of Nairobi, has years of experience both locally and globally as well. And then we've also got from civil society, the executive director of the Kenya Network of Cancer Organizations, also known as KENCO. That's Christine Sitati, who's a champion for the Union for Cancer Control, Cancer Advocates Program, and a coordinator, hub coordinator at KENCO. Thank you very much, Christine, for your time here this morning. And then we've got Sydney Chahonyo, who's a cancer survivor, and will talk to us about the long-term effects of living with that post recovery. And he's a man who's passionate about childhood cancers and changing the landscape in the country, and is from Hope for Cancer Kids. Sydney, thank you very much for making the time. And because we'll also be discussing vaccinations here and the importance and the role of that. And like we said, the theme for this year's Child Cancer Awareness Month of September is Prevent Now for the Future. We'll be speaking to Millicent Amtana. Millicent Amtana is a cervical cancer survivor, and she's an ambassador for the HPV vaccine. She'll be talking to us about the importance of the vaccination and why she had her daughter vaccinated. And then last but not least, and I'm so happy this panel is full of women, we've got Dr. Mary Nyagasi, who's the head of the National Cancer Control Program at the Ministry of Health. She has over 10 years working experience in the field of cancer, particularly in clinical oncology, policy, programming, and health, as well as the management systems as well. Thank you all for making the time for us here today. I would like to just begin with giving each of you about 5 minutes to speak to us about the overall theme that we're speaking about today, Prevent Now for the Future. And in your particular spaces, perhaps you can give us an overview of your experiences. Let me begin with you, Dr. Deborah Omido from Kisi Teaching and Referral Hospital. You're dealing with children on a regular basis. So just give us an overview of this theme and the conversation.
Thank you so much, and good morning, everybody. My name is Dr. Deborah Omido. I'm a pediatric hematologist and oncologist working in Kisi Teaching and Referral Hospital. Kisi Teaching and Referral Hospital is a hospital in Southern Nyanza, and it's a referral hospital for many counties, including Homa Bay, some aspects of Narok County, Kericho, as well as Kisi. Worked as a general pediatrician in Kisi for over 10 years. And while I did that, I realized that there were many children with cancer. And
Dr. Omido, you're hanging. Perhaps,
yes,
if you don't mind, if your bandwidth is a little, maybe you can turn off the video. Sometimes it helps. Might be clearer. All right, you seem to be back on again, carry on.
Yes, so would encounter very many children with cancer and do our best to refer them to the teaching and referral hospitals in Eldoret and Kenyatta. But would find that sometimes people would not afford the ambulance services to reach there, or sometimes they would go but find that the strain of being very far away from home is too much, and they would discontinue treatment that was potentially curable. And as I saw that from time to time, I felt and made a decision to get training in hematology and oncology so that I could learn how to treat these children and that they can be able to get these services nearer home. And so I went for a 2-year training, and it was in a developing country which has the same challenges that we do, but we had mentorship from people from developed countries and people who had pioneered childhood cancer protocols that have brought that improved the cures from 20% to 80 to 90%. And so it was a very exciting time. I learned a lot. And now I'm back in the county, establishing and trying to make sure that we're able to identify these children and treat these children well, so that they can be able to get services that they require closer to home. Thank you.
Thank you, Dr. Deborah. And you mentioned, an issue of training and, capacity. Maybe Dr. Mary Nyangasi, you can now give us an overview of what this is like from your perspective. There's all the issues about cancer management and what is available, but give us your opening remarks, Dr. Nyangasi.
Thank you, Yvonne, and thank you everyone on the call this morning. Indeed, it's a humbling privilege to be part of this panel this morning. So in terms of childhood cancer at the ministry level, we are also very keen to address. We have actually realized that our outcomes for childhood cancer are scandalously low. And as a ministry, we are keen to see how can we really address the serious health inequities that this poses to our children, where just by the fact that they are in a developing country, their location being in Kenya should determine their outcomes for cancer treatment is really not acceptable.
All right, thank you very much, Dr. Nyangasi.
We've actually embraced the World Health Organization call. There's a WHO initiative on childhood cancer global initiative. So this initiative looks at 2 broad areas: increasing capacity to deliver services for childhood cancer in the country. And then the second arm of it is looking at prioritizing childhood cancer at the national level. So making sure that we have childhood cancer issues addressed in the national strategy. And I'm happy to report here that this second National Cancer Control Strategy was actually the first cancer strategy to incorporate childhood cancer. Our first National Cancer Control Strategy did not have any issue or did not address childhood cancer at all. So this time, at least, we have a National Cancer Strategy that addresses childhood cancer. And one of the key things that we are currently working on this year is developing guidelines for rehabilitation and rehabilitation guidelines for children. We have also been looking at the NHIF package for insurance so that it is more embraces the children. When you look at the current package, it's more of an adult package, but we have sat down with NHIF to review that oncology package so that it addresses the needs of children who need treatment holistically. And we are glad because the experts, some of them who are in this room, have been able to give us the national childhood cancer treatment protocols. So these are the same protocols we've given NHIF and told them, you have to treat children holistically. There is no way we can give them partial treatment. They are not small adults. They need to get full treatment because we have a chance of achieving higher rates of cure if we treat them well. So this has been addressed. And also, I think, as you all know, as a ministry, we've also been able to launch the HPV vaccine at population level. and now it's available for all girls. Next month, we are going to introduce what we call a multi-age cohort. So all girls from 10 to 14 years will basically be eligible for HPV vaccination. This is in addition to the HBV vaccination, which has been provided for all infants since 2001. So as a ministry, those are the strategies we put in place, and we are very keen to make sure that we improve access to treatment for children. Some of the challenges that we are seeing where we sit are actually delayed diagnoses. Why? Because of low index of suspicion. There is a very low index of suspicion even among our healthcare workers. So webinars like this are very helpful because our healthcare workers should also be able to identify signs and symptoms early enough if we to improve treatment outcomes. We also have a very low level of awareness among the community. We have had stories of, witchcraft, is it bad eye? We really need to work on our levels of awareness in the community. And I think this initiative is great for us because then we are able to raise awareness. What are the signs of childhood cancer? We need to improve health-seeking behavior in the community. And this can only be done when the people in the community understand what is the signs and symptoms of childhood cancer so that they can come for treatment early enough. We are also aware of the fragmentation in our health systems, the very few centers, as we've heard from Dr. Omido, able to treat childhood cancer. Children basically have to travel all the way to Nairobi, and we are putting in structures to decentralize treatment so that access to treatment in line with the universal healthcare coverage agenda will be achieved at regional levels. So I think in a nutshell, those are my brief remarks, and I'm happy to contribute further to the panel. Thank you.
Thank you, Dr. Nyangasi, for setting out some of the factors that will be needed to address better outcomes of the treatment and the process and, early diagnosis and a number of the issues that you have raised at that level. And we look forward to engaging more in the Q&A session and seeing, what more can be done to address some of the issues that you have set out. And like we said, the conversation today, first of all, is live on Facebook. So thank you everybody who's joining us on Facebook. Karibuni sana. Please feel free to drop in your questions and your comments. Thank you, Mwakoi. I see you on the chat box. Thank you for joining us, as well as a number of others. We've got Maclean Otieno, who's talking about learning about opportunities to together support and address childhood cancers. You're from KEPCA. So thank you very much. Keep those comments coming in, then we'll continue to incorporate them. So let's now get also an overview. We've heard from a pediatric oncologist. We've also heard from government. But what is it like on the other side when it comes to advocacy and in the civil society space? Christine Mugo-Sitati, the CEO of the KENCO, that's the Kenya Network of Cancer Organizations. Christine, your opening remarks?
Thank you very much, Yvonne and the presenters. So it's really great that we are having this discussion this morning. So like I said, just like I've been introduced, I'm from the Kenya Network of Cancer Organizations, and we are an umbrella body for cancer civil society organizations in the country. So these are organizations that deal with the various aspects of cancer control, right from cancer education to screening, all the way to palliative care, patient navigation, psychosocial support, and of course, rehabilitative support for cancer patients, be it adults or children. So we represent the patient groups, we represent the patients, we are the voice of the patients, and it is very important to bring civil society on the table, even as we discuss with government, because this is the voice of what the patients want. This is the voice of the patients. The things that they are going through, the challenges that they might be having, how they would want the system improved, how they would want care improved in the country. So it's quite important for us to be having this discussion. And I think those are just opening remarks. I guess I'll have more time to discuss more into what KENCO does and how we work together in partnership with the various partners in cancer control and even beyond cancer control. Thank you.
Thank you, Christine. Let's now hear from Sydney Chahonyo, who's a cancer survivor and is also from Hope for Cancer Kids. Sydney?
Good morning, everyone. And thank you for giving me the opportunity to speak at this roundtable. It's a bit hard going after the people that have gone before me because they pretty much have said most of what I was going to say. But this just shows you how partnerships can improve the outcomes for the children that we support. Working with people like Dr. Omedo, the National Cancer Control Program and the Ministry of Health, working with KENCO, you find that when we work together, we are able to achieve more. So as I was introduced, I am a cancer survivor. I was diagnosed with cancer of the postnasal space at the age of 19. I was lucky enough to go through treatment locally. And this year I'm celebrating 17 years of being cancer-free. And what that did to me is it made me look at life from a different lens. And I started volunteering at pediatric cancer wards at Kenyatta National Hospital. And I bumped into an organization called Hope for Cancer Kids, of which I'm the current board chair. Now, what we did was Hope for Cancer Kids was established as a parent group organization for parents who had kids at Kenyatta National Hospital. But with time, it was realized that there are bigger needs that need to be addressed. And so we are now a member of KENCO. We are a civil society organization. And what we do is we raise funds to support children from low-income families that cannot afford cancer treatment. As you said, in low and middle income countries, about 80% of the children do not survive. This is very sad because, as you said before, in high-income countries such as the US and the UK, almost 70% of these children survive. 70, actually it's usually above 80. So it means that there's something they're doing that we are not doing. And some of the challenges faced are late stage diagnosis, misdiagnosis, and also late diagnosis because sometimes it's a financial issue. Sometimes it is because it is too far. Maybe they do not have care in the county or the area of the country that they are in, and they have to come all the way to Nairobi. So they need to fundraise. They need to do all those sorts of things to come to Nairobi. They come to Nairobi, they don't have accommodation. They don't know what they're going to eat for the period that they're here. These are some of the challenges that are faced. And this also leads to treatment abandonment because a lot of people, a lot of families are forced from poverty to extreme poverty when they go through the cancer journey, especially with childhood cancer. And there's also the stigma around that. So what are we trying to do in terms of prevention? We advocate, we raise awareness about childhood cancer so that people do not see cancer as a death sentence or as a witchcraft or a punishment from God for something that you did. So we try to educate the public so that they are aware. Number one, that childhood cancer exists. Children can get cancer. Number two, it is treatable. Number three, it is curable. And there are avenues where you can get assistance, such as through our National Hospital Insurance Fund program, where we pay for the NHIF subscriptions, monthly subscriptions, and they get treatment at public hospitals at no cost. This covers most of the treatment costs, not all of them. And it is good, Dr. Nyang'asi, that you mentioned that we are in talks with NHIF. And the National Cancer Control Program has really involved the civil society and the voices of the children, even in putting together that strategy. So it's a good thing that we are working together to see how we can prevent from the front line, so that it is not a top-down, but a bottom-up approach towards solving the issues that are there. Yes, NHIF is doing a lot. The Ministry of Health is doing a lot, but a lot more can be done. And this can only be done if we work together to be able to meet the needs of these children. So I think I'll stop there because of time. We will have more time later to discuss into a bit more of specifics. So thank you very much. Back to you, Yvonne.
Thank you, Sydney. And once again, congratulations, 17 years cancer-free. And congratulations and thank you as well for turning that into the advocacy that we have seen you do for so many years. So thank you for that, Sydney. Professor Ruth Ndwati, maybe we can hear from you now with your opening remarks.
Thank you very much for inviting me to be in this panel. As you have heard, my name is Prof. Ruth Nduati. I'm a pediatrician. I've been in practice almost 40 years now. Dr. Vido was one of my sterling students in the past. And I've worked within the space of Kenyatta National Hospital for many years. So seen the evolution of the problems of pediatric cancer. I think in our discussions today, we are highlighting hepatitis B virus and HPV, but I also want to say that the other viruses that do cause pediatric cancer, for example, Epstein-Barr virus, which actually was first described by people working in Kampala, is an important trigger for Burkitt's lymphoma, which is the other very common pediatric cancer in our region, but fortunately curable if you are diagnosed children at the correct time. Now, I work I'm a teacher essentially. I train medical doctors, and I want to speak about that space. Part of the gaps in the management of pediatric cancers in Kenya is that we do not have enough trained people. We have less than 10 pediatric oncologists. And in fact, I would say maybe half of them, or even maybe 2/3 of them, have been trained within the last 5 years or so, since we started off to say this is important. I have colleagues in my department, one colleague in my department and another who is at the Aga Khan. They are the only pediatric hemato-oncologists for more than 20 years. So clearly there's been a gap in addressing that. Now, so for example, in Nairobi, we have 3 centers where you can get care. That's Kenyatta National Hospital, the Aga Khan Hospital, and Gertrude Gardens Children's Hospital. Those ones have pediatric oncologists on staff. Outside that, Kisii, where Deborah, Kisumu, in relationship with the Cambridge Center there, they have a site that they treat Burkitt's lymphoma and have a partnership with colleagues from New York. And then, of course, the Moi Referral Hospital at the university. So you can really see there's a huge gap in terms of addressing pediatric cancers. Now, for you to have a successful program, you need to be able to make the diagnosis, and the training on diagnosis needs to be everywhere, not just the specialists, not just the pediatricians who we train and who are very competent in making that diagnosis, but all the way down to nursing staff, the clinical officers. And this is where the gaps are. Again and again, we see children turning up with a mass that has been going on for more than a year. They've been to a health facility, and they were given some little prescriptions, a pain medication, come back. And by the time they come, really, we are doing palliative care as opposed to treating patients for cure. Now, once you do show up in a facility, there's a need to have the capacity to make the diagnosis. For example, to the pediatric surgical services, for example, to operate and get specimens for pathology. And it's only in the recent past that surgery has been declared to be a primary healthcare discipline, meaning that we build our surgical services all the way to the ground so that if you walk in, you can get a lymph node biopsy, or you can get an laparotomy quickly to get samples for diagnosis. The other step is the laboratory. Medical laboratories in Kenya are a huge shame. It's scandalous where we are at. There are very few labs you can get anything beyond a hemogram, and stool for ova and cyst. Even, for example, culture for an infection, most labs can't do it. Even county level hospitals are not able to do that. The Ministry of Health employs less than 20 pathologists. In fact, I think the last count was like 16 or so. So if you consider we have 47 counties and we don't have pathologists, then even if you have a sample that is taken, even if you have the tech who stained that sample, if it is not looked at by a trained, qualified person, then you will not make a diagnosis, or you'll make the wrong diagnosis and the wrong treatment will be given. Now, the training of pathologists are medical doctors who specialize specialize after their basic training. So, and the training in pathology is about 5 years. It's a detailed training because pathology is a fairly complicated discipline, but very, very important, a foundation for medicine. We do not have a structured program for training those specialists. Very much, a lot of people coming back for training now are self-sponsored. You know all the politics about counties employing doctors and whether they can come back for training. It's not just about employing doctors. It's not just about these noisy young doctors. The failure in that space means that our hospitals do not have the capacity to actually make timely diagnosis, correct diagnosis, and then subsequently manage that individual in an appropriate manner. And these are the gaps. And these gaps now are not just gaps for children, more for kids, but they're also gaps for even the adults. And that's why you see when before COVID, the plane ride to India was very busy, isn't it? You know, those who could afford could go. And NHIF could also pay for you to go to be treated out there because we have not developed our services. So going forward, we need to be deliberate in training and building a capacity within our own services to prevent. Now, in the space of prevention, we need to strengthen our immunization programs. We already have, as rightfully the ministry has said, we immunize for hepatitis B, but we need to introduce the birth dose of hepatitis B, because I think the evidence now is that babies who get hepatitis B infection in the newborn period are the ones who will go on to have chronic hepatitis and are the ones who are going to be at risk of getting hepatoma, cancer of the liver. But the birth dose, we need to work at the birth dose, and I know that the program for immunization has been having that discussion. There's a lot of investment that needs to be done, but we already give a birth dose of oral polio vaccine. So, and we give BCG at birth. So we really know how to reach newborn babies. And so I think just making the commitment in terms of the money to with the cancer of the liver, which is very common, is that we need better quality control around our food products, and particularly ugali flour, maize flour. Our maize flour, many times products on the market are contaminated with aflatoxin. Now, the combination of hepatitis, chronic hepatitis, cirrhosis, and aflatoxin is lethal. Liver cancer is bad news. Many people die within 6 weeks of their diagnosis. We still don't have great drugs. In fact, I went back to look up the modern literature on it. They're talking of liver transplant as a treatment. We don't have that. So we have to do the prevention story. We need to prevent upfront. In terms of human papillomavirus, we are focusing very much on the girls and giving them HPV vaccine. Actually, we need to immunize both boys and girls. The other cancers that are caused by HPV include cancers of the gastrointestinal tract, so your stomach and esophageal cancers. For men, penile cancers, cancers. So we need to protect both men and women. And if we run programs that give immunization, not just to the girls, but also to the boys, then we are preventing a problem that will be there in the future. We have very, very many young people. 70% of our population is under 35 years of age, 35% under 15 years of age. It is important we prevent these diseases and these problems, because we don't, our health services will be completely overwhelmed in 10, 20 years by this very, very serious chronic illness. Now, the last thing I'll say, and then I'll shut up and let people have the conversation, is that we need to do more research so that we have better treatment. there's a very, there are exciting new advances in the treatment of cancer, so that it's not just the chemotherapy we know, which is can be quite toxic, and the radiotherapy. There are new therapies, immune therapies. There are also new enzymes that have been discovered that are effective. I think tyrosine kinase is sort of like the new big thing in terms of treating cancer, and where people get very, very good results, very high survival rates with those new drugs. So we need to, one, invest in the best, like we've done in the world of HIV, but also to engage in research and to collaborate with the people who are already doing this work. I was very happy to hear Dr. Mido talk about the program in Uganda. The Fred Hutch Cancer Research Center is your major partner in that institution. These are people who we have collaborated with in HIV medicine. So they are our friends. There's a network of friendship in the research world that can be harnessed to get better programs going. Sorry for having talked for so long, but maybe it's an area we feel very passionately about. Thank you. One more thing, sorry. One more thing, Yvonne, I must say. At the Kenyatta National Hospital, we have revamped our management of pediatric cancers. We've reorganized. We now have a ward that is dedicated to pediatric cancer. When you cohort children together, you are better, or patients together, you're able to get better results. The hospital has invested in training people. So we have young pediatric hemato-oncologists, young pharmacists who are experts on cancer chemotherapy. We have an infectious disease service, so that infections are often the common cause of death in patients who are on chemotherapy. So we have actually an active infectious disease training program at the subspecialty level. So there is work going on, but we need this sort of work going on, not just at KNH, but to actually be there in all the big hospitals around Kenya. Thank you.
Thank you, Professor Ndwati. And I was just going to say, it's great to hear from your wealth of experience. 40 years is no mean feat. You rightfully said over 70% of the country are aged below 35. So many of them have not been alive nearly as long as you've been practicing medicine.
Yes.
So it's just important to get all of your insights, and for raising, the issues around training of specialists, around, more research for better treatment, and taking a look at new therapies and technologies that are out there, but also raising the issue that despite all of the challenges, there is work going on, and that more of that needs to be done. So thank you, for just making us aware of what's happening in that field. And we're really so honored to have such a diverse panel of everyone having this discussion today. Last but certainly not least, who has a very personal experience and is also a great advocate for vaccination. Like we said, it's prevent now for the future. That is the theme for September 2021 Childhood Cancer Awareness Month. Millicent Amtana is from Symbol of Hope Warriors. Millicent, your moment now to just give us your opening remarks on this and why this is such an important thing for you, Millicent.
Thank you very much for the opportunity. As you have heard, I'm Millicent. I'm a cervical cancer survivor, and I'm also a HPV vaccine ambassador. So my journey started at the age of 14. That's why it is very important to vaccinate your daughter. At the age of 14, I got my first child, and at the age of 20, I got my third child.
Okay, Millicent, I don't know if you can hear me. I'm sorry, we seem to have a problem with your mic. We can't hear you. The sound is a bit. Maybe get some. very important for us to hear from her, because not only is she a survivor, and she started to tell us a little bit about her story, which is important. Whilst she's doing that, let me just say thank you to everybody who's already in the chat box. And remember also, we're live on Facebook, so wherever you're watching us from, we've got such a great array here. We've got Ntaliwa from Meru County, and then we've got Mercy Sami from Nairobi, Esther Maingi from Nairobi. We've got Joyce Kawira from Meru County. We've got Shaban Francis from Kilifi, Paris Musimbi in Vihiga. We've also got some questions coming in. Joyce Mwende in Isiolo County, thank you. I don't know if we can, let me just give you a few seconds. I can see Millicent is trying to set up the camera. Bruce Chetty from Trans Nzoia County. Eric Mageto from Kisii. Paulina Debo from Marsabit, karibu sana. Sororo from NCDC Marsabit as well. Thank you, this is great. Benedict Kirira, I see you, my colleague at K24. John Gikonyo from the Renal Patient Society of Kenya, good morning. Beatrice Kiburio in Nyeri. So can we see if it's okay? Millicent, do you think you're okay to try, or? No, we still can't hear you. Oh my gosh, okay. Let's give you a few more minutes. We'll definitely come back and start with you whenever you're ready. Just mute your mic and let's continue to work on that. Meanwhile, everybody, there's the Q&A box and there's the chat box. So I'm seeing both questions on that forum from Eric Mageto, Maclean Atieno, as well as in the chat section. So I can see all of that. We're just allowing Millicent a moment to sort out the issues with her mic. We'll get back to that. But in the meantime, I wonder if we can start our Q&A session. Don't worry, Millicent, I will come back to you. We definitely want to hear that, and we can start your session, hear your personal experience, and then get into the Q&A session as well. Meanwhile, let's carry on with now the Q&A and get into some specific issues. Dr. Nyasi, thank you. You had let me start with you. You had given us an overview of some of the issues and how you are sorting them out. But to just be a little more specific, could you speak to us about the National Cancer Control Strategy? It's for 2017 to 2022. We've got about a year left. What gaps have you identified, and how can they still be addressed? We know we don't have much time left. Maybe you could speak to us about that. And also, as you answer that, maybe raise something that Sydney had talked about, which is the survival rates. We've said only 20% of those diagnosed with cancer in Kenya and developing countries survive, while the survival rate is much higher in the developed world. Maybe you could speak to us about some of the measures that government is putting in place to improve that outcome, as well as the strategy, how far we are with that, and what more can be done in the time we've got left.
Thank you, Yvonne, and thank you everyone on the panel. Maybe what I can speak about the survival rate, it's true our survival rates as a country are quite low. We are talking about between 20 to 30% survival rates, and yet in the rest of the world, especially the developed countries, we're looking at 80% survival rates. So what are the reasons? I think some of the issues we've seen, and maybe some have also been alluded to by our other panelists, are issues to do with awareness. We've seen that in the community level, we have a very low index of, low awareness levels. And also a very good point that has been raised is the healthcare worker index of suspicion. So we have noted this. In fact, we have done a lot of surveys in the life of this strategy. And what we've found is that much as we think that our healthcare workers might be aware of how to diagnose cancer, that may not be the case. Many of them are really struggling with how to identify, what signs of childhood cancer would be like. So in this particular strategy, while implementing this strategy, one of the requirements was to improve capacity of our healthcare workers to detect cancers, including childhood cancers. So we've come up with, we just concluded a curriculum for training primary healthcare workers on cancers. And one of the cancers that they are actually going to be trained on is childhood cancers. We have just a month ago put this curriculum on a virtual academy, and this is what we've done in collaboration with NCD Alliance Kenya. Being on the virtual academy, we hope we'll be able to reach more and more primary healthcare workers so that they can be able to access this material online and learn about how to screen, very basic material just to enhance our healthcare workers' capacity to diagnose cancers and refer early. So this is work that we've done just to try and improve the index of suspicion among our healthcare workers. And we hope that with time, it will go a long way in reversing what we are seeing in our facilities. So in the area of screening, we've been able to revamp our cervical cancer screening program. Currently, we are working with 25 counties. We are preventing our women from developing cervical cancers through this initiative. And also in the same initiative, as we are screening our women, we are encouraging the community health workers to bring the girls for vaccination, and also to talk to the communities about cancer, cervical cancer, and so forth. So again, I'm happy to report here that in the same vein, we've been able to develop a curriculum for training our community health volunteers on cancer. So this work, we believe as we implement this curriculum, our community health volunteers understanding about cancer, understanding about what they need to tell the communities about cancer will improve in the long run, the index of, the awareness levels, because they're able to go to houses and talk. When they're talking about HIV, they're talking about malaria. We want to give them confidence to also talk about cancer. So having that confidence, because you've gone through this training and you now understand, we'll put them at a better position so that our people can be more aware, so that when signs are found, our children can come early, our women can come early, our people generally can come earlier on. So it will take time because actually this strategy, as you can see, just started in 2017. We have been implementing it since 2017. We are not able to do everything in a day, but what I'm saying is that it's work in progress. In the area of cancer diagnosis, it is actually, as you heard from Prof. Ndwati, a shame. I agree with that, because in these few years I've been there since the last 15 years, I've seen what happens in the laboratory, especially in the area of cancer diagnosis. We really have a long way to go, and we are working very hard. At the Ministry of Health, as we speak now, we have a functional National Cancer Reference Laboratory. So we have established a laboratory that is looking specifically at cancer diagnosis, and it's called the National Cancer Reference Lab. I'm also happy to report here that that lab has been equipped in the last 3 years. We have equipment for diagnosing HPV testing. We have cytopathology, histopathology equipment. And right now, the lab is even conducting these tests. So our dream is that in the long run, this lab will be able to provide very specialized, especially for childhood cancer. We have tests like flow cytometry, which are not available in the country. So by putting such equipment in a reference lab, then we are able to make sure that our children can get these tests when they need them. And we have a system to send back the samples, the results, leveraging on the HIV and TB sample referral systems. We don't need to reinvent the wheel. We just need to leverage on what is happening and do it well. So these are some of the things we are doing. And even as we are setting up this National Cancer Reference Laboratory, this is the lab that will be supporting the regional, the counties. We are saying every county referral hospital should have good cancer diagnosis, every county referral hospital. So this is the reference lab that will be sort of a center of excellence, supporting the counties to establish their own cancer reference laboratories. So these are some, cancer laboratory, cancer histology laboratories and labs that can actually do diagnosis at a county level. So far, we only have about 9 counties in Kenya that are able to do cancer diagnosis. We want to increase this number to 47. There's no reason why a county referral lab should not be able to do diagnosis for cancer. So those are some of the things we are working on. We actually, a lot of work going on because we also have to do advocacy with the county health management teams to understand the importance of cancer diagnosis, the importance of employing the relevant personnel to run these laboratories. So all this work we are doing to just see how we can improve our cancer diagnosis. In the area of treatment, we have also established regional chemotherapy centers. And these are some of the achievements of this strategy. At least now, if you want to get chemotherapy, you don't have to travel to Nairobi. There are 10 county chemotherapy centers currently offering chemotherapy. And now what we are doing is gradually expanding the capacity of these regional centers to provide also radiotherapy and other kinds of treatment. So far, we are at the final stages of equipping 3 of these centers with the state-of-the-art radiotherapy equipment, so that again, our patients don't have to travel all the way to Nairobi. If you have a child maybe with a tumor that needs radiotherapy, they're able to get it in Nakuru. So this really are some of the achievements of this strategy, and the gaps that we are seeing are that we still have actually the rate limiting step in this expansion of cancer care in our country is the human resource. The human resource capacity is minimal. We have challenges even as we are setting up radiotherapy, where we have been struggling to get the human resource that can run these centers. I'm happy to say that so far, the ones we've established, at least we've been able to get the human resource. But for us to move, for us to establish more, we are in a place where we really need to revamp our training programs. We have been working with our local training institutions, encouraging them to set up local programs because these are more sustainable. When we have training in country, we are more sure that we will have this number of specialists in the next maybe 5 years. So we have also, I can say we've made some milestones. At least now we have some few training programs in Kenya. We are able to train medical oncologists in our country. We're able to train radiation oncologists. Now this program is in its 3rd year. We have also started a training program at Technical University of Kenya, which is training medical physicists. We have training for oncology nurses in Kenya now, and also training for therapy radiographers. So we are keen again to look at how do we start, like for example, pediatric oncology in Kenya, yeah, so that we are able to build our own resources over time. And we are keen to see how this can be done. And thank you very much for this opportunity once more.
Thank you, Dr. Nyangasi. Obviously, there's quite a bit happening, and thank you for being open and honest as well with, where the gaps are, but also highlighting what we've been able to do, the training that is available, some of the capacity that you've been able to build across the counties, and of course, what more needs to be done. Thank you for that. I want to try Millicent again. I haven't forgotten you. Let's see if we can hear you now. Go ahead.
Hello, everyone. Good morning.
Good morning. We can hear you now. Carry on.
Okay. Thank you for the opportunity. I'm Millicent, and I'm a cervical cancer survivor, and also the ambassador of HPV vaccine. So September is a childhood cancer month, and it is also a gynecological cancer month. So it's like they are brothers and sisters. So today, I'll be talking about the future of our children, the future of our daughters. So my journey started at the age of 14, and you can see the importance of vaccinating your daughter when she's still young, because at the age of 14, I got my firstborn, and at the age of 20, I got my thirdborn. And it was the same year that I started having the abnormal discharge, whereby if I knew the knowledge and ran to the hospital, I could have saved my life or saved my uterus. But but by then I didn't have the information, and the cancer cells started developing in me. And because of the stigma, I didn't have the opportunity to talk about my private part of going to the facilities to be checked. So I kept quiet for almost 5 years, and then I got the opportunity to speak out, and I went to the hospital. The nurse told me I have cancer. And when I got the information, it wasn't easy for me, because we know that after treatment, there is a lot of things that you can't do. Yes, you can be treated, you can be very strong, but you will still have a lot of challenges, like you can't have another child if you are planning to have a child, and the side effects you go through for lifetime. So it is very important to protect your daughter. That is the reason that I wanted my daughter to be vaccinated, and I'm glad the government and the Ministry of Health were able to give us the HPV vaccine, and my daughter was vaccinated. As a mother and as a single mother, I'm very happy to feel or to see my daughter growing very safe, within my mind, knowing that my daughter will never go through what I went through. My daughter will never have cervical cancer, because I fought the cervical cancer, and I'm here telling you that it is not easy. Going through the journey, it is not easy. So it is very important to protect your daughter. And where I'm living, we had a lot of misconception, and then people are not who are not accepting the vaccine. But I'm glad, for me being the ambassador, most of them have been able to change their mind, and the women are willing to be tested, and the women are willing to take their daughters to be vaccinated. So I'm here telling you that my daughter, she's very safe, she's very bright, and she didn't have any challenges like the side effects. I have never seen any side effect on her, and she's very bright at school. And thank you.
Thank you so much, and for being very open and honest with your journey, and congratulations. And I like what you said in the beginning, about the nature of cervical cancer, and where you're going to start to talk about things that are very private, but that you finally got the help you needed, and just speaking about the importance of vaccination, and that you have your daughter vaccinated as well, which really is the theme for the session today, which is Prevent Now for the Future. That is the theme for this year's Childhood Cancer Awareness Month 2021. So now we'll come back to you, Millicent, in a moment, and then just pose a few questions to you. But thank you for your opening remarks. And we are carrying on with our conversation. And just as you can see in the chat box, there's such great engagement there. So keep that going. Just a reminder for those of you who are my colleagues in the media industry, please introduce yourself so we know where you're from. Wanjiro Boro from Kameme TV, karibu sana, asante, and thank you to everybody who's joining us here on Zoom and live on Facebook. I'm seeing so many questions and comments already, including for you, Dr. Nyang'asi, from your presentation. So keep them coming, and we will get to them in a moment. And so just a reminder to all our panelists to make sure that we keep our responses precise, so we can have more time for questions. So let me go to you, Christina, because we've heard from Dr. Nyang'asi and what they're doing with the strategy 2017-2022. We've heard already what they've been able to do. What are some of the gaps that the National Cancer Control Program is facing. And so my question to you, because you'd already talked about the role of civil society, maybe you can talk about that a little bit more in addressing the needs of the cancer patients and the survivors. But then as you speak about that role, could you also tell us how you hold government accountable? We've just heard about the strategy program and what they've been able to do, but could you speak to us about holding government accountable to some of the commitments that they make in this space?
Okay, so thank you very much, Yvonne. And so just speaking into the role of civil society in detail, I had mentioned that KENCO being an umbrella body, we have quite a number of member organizations within the network. So currently we have over 36 organizations with us working together. And these organizations are spread across the country. I think this is important to mention so that even people who might be joining or might be knowing people who are outside Nairobi, they should not feel like these organizations are only based in Nairobi. We have members across Kenya. We have as far as Kilifi, Turkana, Kisumu, Embu, Meru, Isiolo. So people should feel free to look for these organizations within their areas, because we do support with a lot of necessities that the patient needs. So, and we come together for that united response against cancer against cancer. So just like I had mentioned earlier, our members that do support when it comes to a lot of cancer education and awareness. Dr. Nyangasi mentioned that this is quite an area that needs improvement in the country. And also there was a survey that was done in 2020 by the Union for International Cancer Control. And Kenya was one of the countries that participated in the survey. And at least 51% of Kenyans showed that there is need for cancer awareness to be improved in the country, and they felt more needs to be done in that. So quite a number of our members do participate in educating the public about the basic risk factors, the lifestyle that they should undertake, and also in calling on our members on the public to go for early screening for the sake of early detection. We also have members who actually do the actual screening on the ground, as much as they're educating people to do this. So as they create demand, they offer the services, just complementing on what our government is doing. There's patient navigation. So just like Millicent said, when you get that cancer diagnosis, where do you begin? How do you go about it? Then for the last couple of years, just before the cancer centers in the counties were started, most of the healthcare was being given in the big government facilities. So there you have a cancer diagnosis, you are from a rural setup, you've just been sent to Kenyatta. So you need somebody to work with you physically, patient navigation physically, to show you around the facility, where to get the services, which rooms to go to. And then of course, in your cancer journey, you have diagnosis, you have to go for these next tests, you now need to see a doctor, you need to see a counselor, a nutritionist, so somebody to take you through that. And you have member organizations who specifically do patient navigation. Sydney alluded to the fact of treatment support. For example, so like Sydney is a member, his organization for Cancer Kids is a member of KENCO. So for the likes of him, they support children with NHIF. Yeah, there you have a child, they need treatment, but now when NHIF is paid for that child, then at least they're able to access some services for free, since it's covered by NHIF. So we have a number of members like that. And there are also those that do give some financial support, especially for the adult cancer patients. I know it is not enough, because of course cancer treatment is very expensive in this country. So it is not enough, but at least it does assist some patients. Then we have most of the groups, most of the organizations do offer patient support in terms of psychosocial support. So this is counseling, working with this patient. I mean, if I get a cancer diagnosis now and I meet somebody like Millicent, who's been through that journey for a number of years, then I get quite a lot of encouragement from her. I'm able to get some hope. And what we need in this country is to give hope to cancer patients. It is not a death sentence. There is treatment available in the country, and we are getting quite a number of survivors these days. Then, of course, rehabilitative support. Some of the cancer treatment options are like surgery. So there you go, you lose your breast. So you will need a breast prosthesis. You lose your limbs, for example, a leg, a hand, you will need some support with that. So we do give quite a number of our members will support in terms of breast prosthesis, colostomy bags, yeah, the various kind of rehabilitative commodities that are needed by cancer patients. Then, of course, now those are our members. What does the umbrella body itself do? So at the secretariat level of KENCO, we also carry out a number of very critical activities. Number one is capacity building of our members, because yes, we have these organizations. Some of them are community-based organizations. We have trusts, we have foundations, and we need to build their capacity in matters cancer. Yeah, most of them were started by people who've been through cancer or close relatives who went through cancer, but we need to give them the basics of cancer. So we do regular training programs in terms of cancer cancer science for lay advocates, for them to understand the science behind cancer, exactly what is this we are dealing with, and giving them basic information that they can be able to cascade back to the grassroots levels. We also support in terms of trainings and sensitizations on the current policies and guidelines that are there. Dr. Nyangasi from NCCP, the team does develop some guidelines around cancer control, and as civil society, we get involved in that development. So it is now ensuring that our members get to know, for example, the cancer screening guidelines. Members need to know this so that even as they go out there doing the screening, they need to know what needs to be done. We have quite a number of policies in place, so our members have been sensitized in this. We've also sensitized in terms of the budget process, the budget making process, so that when it comes to public participation in budgets, then cancer control members are there and they are speaking into that budget. What do they need to see? We need more resources in the NCD sector. We need more resources around cancer control. So we have to advocate for that. Yeah. Then of course, networking for our members. As much as they are, for example, in Kisumu, you might find we have 5 members. They need to know each other. They need to plan activities together just to be able to harmonize their work plans and use the little resources in cancer control that are there for greater impact. So we do a lot of networking. Then, of course, organizational strengthening for Kenko itself and for our members to be able to run as real organizations and not as briefcase organizations, so that we can attract support into cancer control. Then, of course, external relations, we do a lot of that as Kenko, just to bring partners together. We work closely with professional associations within the oncology sector, the private sector, various partners and donors within cancer control and even outside of cancer control, because cancer needs a lot of multi-sectoral approach. Everybody has a role to play. Then, of course, the fourth estate, I'm happy they are here, quite a lot of representation from the media, just sensitizing the health journalists, working together with the health journalists. And I think I really want to applaud NCD Alliance, because this is something that they've taken very important. They've taken it so importantly that it is good to have media representation and participation, because then our health journalists will keep the cancer agenda in our rooms, in the houses, and wherever we go. That cancer agenda is on top of the list, which is important to give hope into this country. Then I think I also want to mention that we do a lot of advocacy. So this is identifying key issues that are within cancer control that need to be addressed. For example, right now we have a great challenge when it comes to health financing. NHIF is not enough. NHIF does not cover everything. So what more needs to be done? Because cancer can actually make somebody very poor. You get to sell a lot of your property because there's a lot of out-of-pocket spending. Right now, NHIF, as much as we are calling on the public to do screening, they do not cover screening. They will not cover diagnostics. So they will cover treatment. We applaud them for that. But again, the treatment is not enough, the kind of cost that they give. So what more needs to be done? So ensuring that that agenda continues over and over again and having a lot of discussions. Dr. Nyangasi talked again about late diagnosis. So we, as part of advocacy and education, as Kenko, we run a project with health facilities. Most of them are cancer centers and centers that provide palliative care to cancer patients. So here we have, we provide cancer education materials for patients and caregivers. So these are small booklets that contain a lot of information on cancer, and we offer them for free to newly diagnosed cancer patients. And so for us, we fundraise for that. We print the booklets, we distribute them to these cancer centers. At the moment, we are working with 51 facilities across the country. And these facilities, the health workers, we sensitize them on this basic information. And most importantly of all, how to break bad news. Yeah, because a cancer diagnosis is quite tough. So we need it done in a very sensitive manner to the patient to ensure that they actually accept that and they are ready for the treatment journey, just to ensure that adherence is there. So we provide information to the health worker, the booklets, then the health worker will pass these booklets to the caregiver or the cancer patient themselves. Then As we do this, we also do a lot of frequent webinars within the various cancer months. We are very keen on celebrating the various cancer months because each day is a cancer day. So we do the webinars with the health workers just to increase their knowledge and to ensure their suspicion index for cancer is high. Then also we do a lot of fundraising for rehabilitative commodities. So like in the past couple of months, we've given out a lot of breast prostheses, stoma bags, adult diapers for patients with cervical cancer, and all these kind of commodities that we can get our hands on. And we welcome all forms of partnership so that this is done for the sake of our patients. Then Yvonne, you asked a question about accountability to government. So like I said, we work hand in hand with government, as civil society and government. For example, we work closely with the National Cancer Control Program, the National Cancer Institute, so that we are able to influence policy changes. As these materials and policies are being developed, we ensure that we are there on the table and we can give our feedback. One thing I want to applaud NCCP is that actually we have the various technical working groups for the pillars, the pillars that are within the National Cancer Control Program, and civil society is actually represented in these technical working groups. So even as we work, we can easily provide a voice for the patient and what needs to be done in the country. And so even as the guidelines are developed, then supporting the government in terms of dissemination and also ensuring that the dissemination is done. NCCP does carry out a number of reviews. We recently had a review for the National Cancer Control Strategy. So civil society being there, asking all the tough questions, what are the gaps, what needs to be done, just keeping them busy, so to speak. Then of course, getting involved in the various forums that are called by the various government sectors, National Treasury, going in there, giving our feedback. For example, early this year, we were with the National Treasury as KENCO, trying to give feedback when it comes to issues of tobacco taxation, alcohol taxation, taxation for sugar sweetened beverages, because these are some of the things now, these are some of the risk factors for cancer. So I think all these deliberations and of course, involving media, when things need to be done, involving media, what needs to go out to the public, what the public needs to know, and involving the various government line ministries. So I think that is just a brief of that. And we hope that someday actually we'll be able to bring down our cancer numbers in this country. Thank you, and back to you, Yvonne.
Thank you, Christine, for such a detailed, comprehensive a vision of where you want this country to go with respect to cancer treatment. Dr. Amido, you're on the ground, you're dealing with all of these issues that have been raised here today, the importance of and the role of early diagnosis, standards and guidelines around intervention measures. So speak to us about the challenges of childhood cancer treatment in the country, incorporating a lot of what has been said, and also just, taking a look at what is being done to facilitate timely diagnosis and better outcomes. And of course, for persons like Sydney, who we are celebrating today, and many others, including Millicent, the long-term effect of childhood cancers, particularly for the survivors.
Thank you for the opportunity. Yes, we encounter many children with cancers. We encounter all types of cancers, both solid tumors, liquid tumors. And one of the major problems is that patients don't even know about insurance. And so getting them into NHIF has been a challenge, but Hope for Cancer Kids has assisted us to be able to get some NHIF for them. However, sometimes the activation is a bit late, and many childhood cancers multiply very quickly. And within a month's time before the activation has been done, you can even lose the child. And many times you need to start the treatment quite early. We've been networking, having public-private partnerships with some private hospitals who are able to procure some of the therapies that are not available within the government sector as well. Then the other other challenge is the diagnostics. So we've been partnering with hospitals like Eldoret, where we send some of the samples by the courier, and then get the results. Sometimes the NHIF does not cater for that, so we sometimes mobilize the donors who are assist us in paying for some of the extra costs that are not covered by the NHIF and some of the tests that are not covered for by NHIF. Then another issue is blood products, especially for childhood leukemias and even many other, even some of the solid tumors. As you continue the chemotherapy, the platelets can become very low, the blood can become very low. So there is need to strengthen the regional blood transfusion centers so that they're able to provide blood products that can be given to the children so that they can survive. You may have the chemotherapy, you may have the right diagnosis, but if the child begins to bleed and you don't have the platelets on time, you don't have the blood on time, you can easily lose those children. So not very many regions, I think it's only Nairobi and Eldoret that are able to produce platelets, yet there are regional blood banks all over the country. These need to be strengthened, and this can even requires in a cooperation of the Kenya Power and Lightning companies to strengthen the electricity that is required for the machines to make the blood products to be available. Then we need constant supply of antibiotics and antimicrobials and fluids and other supplies, because these children can easily get infections, and we really need to be able to have constant supply of these medications. So sometimes we have stockouts within the hospital, and sometimes we have to reach out to the other institutions. But we are continuing to advocate, and I believe there's light beyond the tunnel. We are continuing to advocate, making sure that things are availed in the hospitals. And slowly by slowly, we are making it. We are managing to diagnose, we are managing to treat, and it involves a lot of networking, contacting many different people, the different patients, and we are beginning to succeed. Yeah, but there's a lot, there's room for a lot of improvement, and I believe if we are just consistent and we work together as a team, we'll actually get there and be able to cure very many children.
All right, just while I'm still with you, could you speak to us about the level of care that is offered at the Kisii Referral Hospital where you are, and how that compares to others? We've already heard that there's 9 counties that can offer cancer diagnosis, and a number of centers that have been opened countrywide, not as many as like, but we're making quite some great progress. Yes. And also human resource capacity that is limited in this space, such that you have the centers, but staffing them with the right staff and the right quality, people who understand diagnosis and diagnostics and running the specialized machines and processes is to talk about. Could you speak to us about that, and what more you would like to see that would improve outcomes for childhood cancers?
Yes, so we are fortunate in our hospital. We have 4 pathologists in the county, and so once we sensitize our staff on how to know the danger signs and the warning signs of childhood cancer, they're able to refer the patients promptly, and we are able to take samples. Some samples can be worked on in our laboratory. The ones that cannot be worked on, we have a courier service that is able to send them to the hospitals that can be able to make the diagnosis. And now once we make the diagnosis, we are able to procure the chemotherapy required for that particular patient, and then we usually start the care and continue with the supportive management through networking. Yeah, so we've been able, we have children with the leukemia who we have started treatment on. We have children with the neuroblastomas. We have children with various cancers who we've been able to start treatment on. And that it cannot be, you have to work with people, you have to network, you have to always look for help from all organizations to be able to get this done. But it is possible. It is not impossible. It is a possible thing. So long as there's networking and that you're focused. Staffing is an issue. We have shortages of all cadres of staff, from the laboratory technicians to the nurses and to the medical officers and even clinical officers. But we make sure that we work together as a group. The situation may not be very ideal, but when you're dedicated and you're passionate about something, it becomes possible. Yeah.
Indeed. Thank you very much, Dr. Omido, for that. Sydney, from Hope for Cancer Kids.
Sorry. Yeah.
Sorry. Yes. Carry on, Deborah.
I think I've mentioned it. It was about the blood products. We also need to sensitize the community about the importance of donating blood and strengthening the capacity so that the blood products can be made and be available. Because once you have good blood products, you can be able to support these children because many of them can die just from bleeding and anemia. So also sensitizing, making sure that we have organized blood drives and organized voluntary blood services is very key in many of the childhood cancers as well. Thank you.
Thanks for emphasizing that.
Maybe I can make an observation.
Yes, Professor.
I think we need to have a human rights approach to this problem of cancer. What Dr. Omido is telling you is that as a pediatrician working as a pediatric hemato-oncologist, she has to be knocking on every door to beg for resources. People go to the office and find the resources they need to do the job. But the health workers who are taking care of these kids who have cancer, even HIV, because we have slidden back, we are knocking on doors. We are sometimes haranguing government officers. They are our friends. They won't know what should be done and they're doing their very best, but they are having challenges. We need to have a human rights approach. We need to implement our constitution about the right to health, the right to safe, modern health services. The parent of a child who has cancer, leukemia, should not watch their child die because there was no blood products, or should not have a child deal with the toxicity of antibiotics that were not the right antibiotic for the infection the child has. They should be able to get a laboratory test so that you know what you're treating. So I would say as a group of people or organizations that are advocating for healthcare and safe cancer treatment, that you can't hear me. I'm saying we need to bring in the lawyers on board as well. We need to have a human rights approach. The right to health. You know, the importance of knowing you walk into a hospital that the health professionals are competent. We've invested in having the right people to be there. I mean, how many hospitals do you walk to? Your child who has cancer, you're sharing a bed. You're next door to the child who has an acute infectious infection. So even if we're giving you good treatment, the risks that are just associated with that care. So we've made progress. We have had that policy, but I don't think we're not doing enough. And especially now that we have taken care of a lot of the infectious disease, we have good immunization programs, etc. A lot of the illness that people will face, a lot of the NCD that children will face is actually cancers. And so the appropriate care, we have to just invest on that. And and successful programs are the ones that government steps in. Government has the resources. Okay, so in this discussion, we've identified we have a problem of safe blood services. This doesn't affect just the cancer patients, it affects many other people. For example, women, a lot of women die. Maternal mortality is very high because there was no blood, right? If it is availability if it is training of pathologists, what money is being put on the table to train pathologists? What money are we putting on the table to train the technicians, the technologists that go with this space? That's the kind of development that you require to actually change that space. If you look at our partners, like for example, the center in Uganda, which is a partnership between the Uganda government and Uganda government and I think the Fred Hutch Cancer Research Center and several other funders. You can see what money they have put on the ground and they can see the results of that investment. And we have to be able to identify what are the priorities, what are the, in any problem, what are the key that you need to change so that you actually get the results that you require. I'm afraid I don't think we've done that very well here in Kenya.
Yes.
Another aspect I'd like to talk about, especially for children, is malnutrition. Cancer causes malnutrition. And as of right now in the ground, in most of the counties, there has been a short supply of products for nutritional support. Many children are malnourished. We know the products that they're supposed to get, but the products have been unavailable. And when you're treating cancer, which is one of the diseases that causes malnutrition, as well as many others, you cannot be able to treat effectively if the supportive management is not there. And so as a country, we really need to make sure that we avail all the nutrition products and that they should be available way down to the county, and that people don't have to pay for them, because many people who have the malnutrition cannot afford even to pay for the malnutrition products. So this is something that has been lacking and has really gone back. We have really regressed in this, because in the coalition government at the very beginning, there was a Ministry of Public Health and a Ministry of Curative Services. And so budgets were made for public health, which included nutrition and other services. Right now, when we have one single ministry, we find that there's no budget allowance for many of the things in public health, including nutrition. And so you find that that is one space that is really causing a lot of mortality in not only children with cancer, but even children in general, that needs to be addressed as soon as possible.
Yeah, okay, and thanks for addressing that issue, and also for Professor Ndwati reminding us of a human rights approach to cancer treatment and perhaps to healthcare in this country. And just to underwrite that, Article 43 of the Kenyan Constitution provides that every person has the right to the highest attainable standard of health. And so it's about making that a reality in terms of the investments that we put in place, and financial investments at that. Sydney, I want to come to you. Professor, I'll come back to you in a moment. But first, let's hear from Sydney, who's a cancer survivor himself and now doing lots of great advocacy work and some help at the Hope for Cancer Kids. So this is something you understand very well. From a very personal perspective. So what are some of the challenges, of children living with cancer? What are the challenges they face? What kind of support do they need? And, we've already heard quite a bit of the help that is provided by Hope for Cancer Kids. And what recommendations would you make to the government and all the other stakeholders who are here in terms of, improving the outcomes, the quality of life, improving the survival rates as well?
Thank you, Yvonne. I like to say that it's good to hear that we are all speaking the same language. A lot of the issues that we are picking up are pretty much the same. Support, prevent, advocate. About 400,000 children and adolescents are diagnosed with cancer every year. About 80% of these fall in low and middle income countries, such as Kenya. Every 3 minutes, a child dies from cancer. And I like what Professor Ruth Ndwati said about implementing a human rights approach, because healthcare is a basic human right. Now, how do we support these kids? We pay for NHIF, yes, but NHIF is limited. A lot of the issues that these children face, number one, treating a child is not the same as treating an adult. For example, is a in adults. So we need to invest heavily. The government needs to invest heavily. I'll go back to HIV and AIDS in the 90s. They invested and invested and invested. When at the point of diagnosis, there's a counselor who sits with you, takes you through the journey. ARVs are pretty much free nowadays. Cancer medications, access to medicine is one of the biggest challenges. And when you find that someone is told this is the cost of the medication, and then they go home to look for ways to raise funds for this, by the time they're coming back, the child is in such a bad state that it's basically end-of-life care that is being given. Dr. Omedo spoke about nutrition. The child, while they're in hospital, they're given nutritional supplements when they're, as inpatient. When they go home to recover between their chemo cycles, they don't have these. We don't even know whether they're having 3 square meals a day. By the time they're coming in, they might even be in a worse state than when they left. So these are some of the issues that need to be tackled, because with no investment, then we can't really do much. Diagnostics. NHIF is doing a very great job, but it is limited. some of the diagnostic procedures like examination under anesthesia, for example, it is a surgery because it is done under anesthesia. NHIF has a limited number of surgeries per year. And this is not just for the child who has cancer, this is for the whole family because you can't register a child. You're registering the parent with the dependents under the parent. What if you have 5 other children? What if there are other surgeries to be done? What happens to this child? Can we start discussions about having a separate NHIF cover for people with cancer, for children with cancer? And also that period of waiting for NHIF to be active. It used to be 3 months. NHIF at that time reduced it to a month for Hope for Cancer Kids. But some of these cancers will double in a week's time. So by the time you're waiting for that month, you're wasting too much time in between. So we need to find a way to bridge that gap so that from the point of diagnosis, the child is able to quickly get coverage and start treatment immediately. We're talking about vaccination, HPV vaccine, hepatitis B vaccine. For example, HPV is something that can develop in your body for about 10 years before it manifests as cancer, the human papilloma virus. So there's a lot to be done in terms of educating people so that they are aware of these things, so that they're preventing themselves from getting this. Quality of life. I wear a hearing aid. Last week, we were looking for funds to provide a child who had had an amputation, and she had a wound that was not healing, and we needed to fundraise for that. This should be covered in the basic package. The hearing aid, I pay for it myself. I'm not sure how far the government has gone in terms of providing things like that. Prosthetic limbs, prosthetics for people who have had mastectomies. And in terms of the quality of life, psychosocial support is very important, and it's something that people don't talk about. These children are isolated from their families. They are isolated from their support systems. They're in a hospital. In Ward 1 in Kenyatta National Hospital, you find kids who are there even for 1 year. We usually do art therapy sessions with them on Thursdays. Because of COVID, that has not been done this year. But it's just that element of even education. They're out of school for a period of 1-2 years. How are their minds being engaged? How can you find a way to make them productive and kind of stop concentrating so much on the cancer, but to continue living? These are just some of the things I can talk about. I've talked about and support. We need a report done. They will ask, what are the statistics? What is going on? A lot of the things we are quoting are from the US, from the UK. We need to invest heavily in research so that we can be able to turn the tides. These are just some of the things I'm thinking about. I know I will not be able to cover everything. I saw a question about how do we reach children from Elizabeth Nkatha. How do we reach the children? We work with the community health workers. We work with people like Dr. Deborah Omedo in different public hospitals. And we work with social workers as well, who say these are the kids who have been diagnosed. They're from very poor backgrounds. Even that 500 shillings for NHIF, they are not able to afford it. So that is part of the system that we use, so that by the time we are getting a referral, it is coming from the point of need. We are raising funds to support pediatric oncology units. And we would like to see, as Dr. Nyangasi was saying, they're trying to equip a lot of radiotherapy centers around the country. We hope this is not centralized in urban centers, but it gets to a point where even if you have, the way we used to have 7 provinces, even if you have 1 radiotherapy unit in each of those 7 provinces, so to speak, it will reduce the burden on the referral hospitals like Kenyatta National Hospital, and the burden on the healthcare workers, the nurses, the doctors, and the parents, because then the system starts to become a bit more efficient. A couple of years ago, the radiotherapy waiting list was about 2 years. By the time you're coming, 2 years, that's a death sentence. But things have moved on quite well. And there's a lot being done in the government. There's a lot being done in civil society. I would also like to talk to the corporates. Invest in cancer. Invest in cancer. There's a lot of CSR being done out there. Cancer is the 3rd leading cause of death worldwide, after infectious diseases and cardiovascular diseases. Why are we not giving it the importance that it deserves? We should go back Look at what was done in the HIV case. Yes, it takes a long time. It cannot be done in a day, but there are steps you can take to move in the right direction. And yes, we are making baby steps. We are not walking fast enough. That is it from me. Unless there are any other questions, I will leave it at that to give the other panelists a chance to address these issues. Thank you, Yvonne.
Thank you so much, Sydney, and raising just a host of issues, and also just showing us where the challenges are, but also what's been done and some of the improvements that have taken place over the years. And just a quick one, because we're having the question and answer session, in a short while. And so also in the chat box, I encourage our panelists to also respond to some of those issues if you can. In the chat box, there's various ways of trying to address those issues. We can't raise and indeed address all of the questions here in this forum, but if you can, just click on the chat box, see some of those questions, and you can respond. You can also do the same in the Q&A session as well, but we'll have time for that. So I want us to move really quickly. Professor, I want you to sort of have the final question. And if you can do it in as short a time as possible, I know that might not be possible, but one of the things that we want to talk about, because the theme for this year is prevent now for the future. And one of the ways to do that is by vaccinating. And so far, we've got vaccinations for at least 2. So that's the HPV and hepatitis B. So tell us about, Kenya has, embarked on a vaccination program. Why are we vaccinating girls? Why are we vaccinating them so young? And what about the others? Because that's just 2. What about the other types of cancers for which we do not have vaccines? What does prevention look like in that space?
Okay, thank you very much. And I'll probably just talk about the three viruses that we talked about earlier. And let's talk about Epstein-Barr virus, which is probably the oldest, one of the first viruses to be linked to cancer. And for us, it's related to Burkitt's lymphoma. This is a mosquito-borne virus. So in terms of prevention, use of mosquito nets to protect you from mosquito bites, use of insect repellents on the skin, environmental control of mosquitoes is actually a very useful way of prevention for Burkitt's lymphoma. And it will also prevent other infections that are mosquito-borne, like dengue, chikungunya. There's a whole, apart from malaria, which we all know about. So good public health in dealing with mosquitoes and preventing those mosquito-human contact will make a difference and make a difference long-term. In terms of liver cancer and hepatitis B vaccine, I think the next step is to introduce the birth dose of hepatitis B. When little babies, young children get when you look at who gets chronic hepatitis, the risk is greatest among the young babies. So if you're exposed to hepatitis B virus as a very young infant, as a newborn, you have a much higher likelihood of eventually developing liver cancer. So chronic hepatitis and then liver cancer. So a focus, if we can introduce hepatitis B birth dose into our programs, will go a long way. We'll be walking the step of developed nations in terms of that prevention. But related to hepatoma is also good quality assurance around the food that gets to the table, both for human beings and for animals, and particularly that animal feeds and human food should not have aflatoxins. So that whole industry and regulation, surveillance, the whole works. When you go and talk about cancer prevention in the community, are we talking about storage of grain? Safe storage of grain, and maize, groundnuts, and also omena when it's dried and it's been dried and kept and not kept well. These are very vulnerable foods in terms of aflatoxin, and if we're able to work on that, that's again a very important step in terms of long-term prevention of cancer of the liver. Alcohol, alcohol consumption, alcohol, and the story is alcohol, cirrhosis, liver cancer. You know that we have a huge problem of alcoholism in our country. In fact, alcoholism is a big deal among particularly African men, have a 4-fold higher risk of alcoholism compared to men from many other parts of the world. So addressing the issues that make our men vulnerable to alcoholism. So people who are in the social sciences, in the psychological sciences, what is it? What is it that's driving this culture of drinking and into alcoholism, and also alcohol that is bad alcohol, the changa and all the other stuff. And then when we come to the HPV, we've already said that the human papilloma virus does not only cause cancer of the cervix. Yes, cancer of the cervix is the 4th commonest cancer globally, and hence the priority. But it also causes other cancers like anal cancer, cancers of the gastrointestinal tract, your esophageal cancer, your penile cancer. So vaccination should actually be to both boys and girls. Why we only are vaccinating girls is because the cancer of the cervix is big and that's the priority. But if we have enough resources, if we commit if we have, and then also the research was prioritized among girls. So, you know how governments make decisions is that you must have the evidence, you must show that it is working before you invest in a national program. So the research was initially among young girls. So now I think there's a need to do the work to justify scaling up the immunization to the boys. In other countries, well-developed nations, for example, North America, Australia, they immunize the boys as well, and they are starting to see a decline in the new cases of these cancers that are caused by human papilloma virus. So that's what I would say in terms of prevention and what needs to be done.
Yes, and thank you for raising a number of those issues, food safety, alcohol use, and a number of other issues, particularly for the types of cancers that cannot be, prevented through vaccination. And Dr. Deborah made a response.
One thing, just one thing forgotten. The other really, really important thing is quality of the air we breathe. So environmental pollution with the use of biomass fuel at household level. So when we promote the use of cooking gas, and other clean fuels, we also are actually potentially preventing cancer, particularly lung cancer. So that's just the other one. Thank you.
Thank you, Prof. I want to get quickly into some questions and comments, if possible. Maclean says, perhaps you can look to the Kawempe home care in Kampala, Uganda, Prof. I don't know if that's what you were referring to a little earlier when you talked about what was happening in the government of Uganda, that they present a great example of holistic psychosocial support for children with cancer and other life-threatening conditions. There's a website there for those who may want to reach out. Maclean, you also say that perhaps we should consider developing cancer education materials for children as well, reaching out to KENCO, NCCP, and the National Cancer Institute as well. So let me see a couple of questions here. Eric Mageto, I think this one would go for you, Dr. Nyang'asi. You say, what strategies does the Ministry of Health put in place to prevent cancer now for a future Kenya? I want to take maybe one other question so that we can answer one or two. I think we may have time for just 2 or 3. Professor Nduati, this is from Anne Mikia. It's directed to you, Professor Nduati. You talked about new cancer treatment with a higher survival rate. Are those therapies available in the country? She asks even countrywide. And then Joyce Nyaga, who had, I think, a couple of questions as well. You say, how can we be assisted in diagnosis, at least the referral of biopsy to the National Cancer Center lab for early diagnosis? And I think, yes, you did raise, kindly let us know the center so that we can refer appropriately. I believe that was from you, Joyce. So let's have those 3 questions answered. Dr. Nyang'asi, I think we'll begin with you. in terms of the strategies that have been put in place. And there's also one here, I don't know if you can answer, I'm just going to try and make it a cocktail. Ben Kirera, who's a news reporter at K24 TV, wants to know how we can make treatment affordable and how we can enlighten the society on early symptoms to look out for. Dr. Nyangasi, let's begin with you.
Thank you, Yvonne, and thank you everyone again for those questions. So what are we doing as government to prevent cancer? I think one of the strategies we are using and is actually what is the agenda of this panel today, and that is vaccination. We have actually rolled out the 2 key vaccines for cancer, which is the HBV, hepatitis B vaccine, and the human papilloma vaccine. Globally, these are the 2 recommended vaccinations that are currently being used to prevent cancers, the liver cancer and cervical cancer respectively. And the reason that we are starting with the girls in our country is actually issues to do with the resources that as a country we are able to allocate for this vaccine, number 1. And number 2 is also the global vaccine availability. Yes, you can have the money, but that doesn't mean you'll get a vaccine. You can see even in the context of the COVID, the money is there, but getting the vaccine, getting yourself on the supply chain to get the vaccine is a challenge. Actually, we really lobby even to get the few doses that we've been able to get for the country. You have to sit at a global forum and lobby really seriously. So it's also a matter of the availability globally. Every country is trying to vaccinate their girls and their boys. So you sit on the table and lobby really hard. And so what you get is what you come back with and hope that your population can be able to consume. So I think those are the 2 maybe things I can say about why we are only vaccinating girls. It's what we were able to get on the table for Kenya after years of waiting on the negotiation table and really lobbying hard. And then the other thing that I want to say is, I want also to, as a government, we usually work through our stakeholders. That thing has to be very clear. We don't work as Ministry of Health in isolation. We have technical working groups. These are the technical working groups that inform the key decisions we make and the things we are able to do. So far, what we've been able to achieve is through the technical experts that sit in these technical working groups and guide us on what we need to do next. So for example, I'm really sad to sit here and hear that in Kisii, we have 4 pathologies and the lab is not working. Really, we need to sit down even with the hospital administration and find out what are these equipment not here that need to come on board, because having 4 pathologists and a lab is not working is really not acceptable. Those are things that can be resolved just by sitting at that level of the institution. And I think I've learned that through advocacy and working together, and we are able actually to move a lot of things that previously seemed impossible. So technical working groups, we are all welcome to join us and see how we are able to improve the issues of cancer management in our country. We cannot do everything we can't work in isolation. We really appreciate the civil society because they have sat with us, and a lot has been moved because of civil society. If we look at even the HIV space, the issues of treatment 20 years ago, HIV drugs were expensive drugs, but through the momentum of the civil society and everybody sitting together and saying, no, we need to really make HIV treatment affordable. Right now we can sit and say HIV treatment is free. So also for cancer, I think there's an opportunity. So we really need to just learn from what has been done previously, learn from the giants in these areas, and I think we can make a difference. So yeah, what I'm also trying to say is that in the issue of cancer treatment, we are also alive to the high cost of the cancer treatment. In fact, as a nation, we are implementing UHC. In the UHC agenda, financial risk protection is really key, access and financial key protection. So from the report we got from the consultants who did the initial UHC strategy and what we need to do, cancer was actually identified as one of the key diseases that causes catastrophic health expenditure. So we are looking at our teams here. What do we need to do? Already we have an idea what we need to do, but we cannot, as you have heard from our previous panelists, we cannot say that NHIF is the entire solution. We need to look at it more holistically. We need to see, right now, again, what I need to mention here is that 10 years ago, 20 years ago, Kenya was a low and middle income country. So even the way it was rated among the global partners and collaborations was different. Now we are transitioning to a middle income economy. So that means a lot of things, especially in terms of funding for our public health programs. So we need really to sit down together, agree what we need to do, and then we'll be able to get solutions for many of these things. And I believe there is hope. We are able to make a difference, and we know that we can be able to put in strategies that can be able to change the picture. Thank you.
Okay. All right. Thank you. I just have one more question for you from the plenary. And Millicent, I see your hand up. I'll be coming to you in a minute. I have like 7 minutes to wrap this up. So the next responses, I need to be a little quicker. Sadly, time is not on our side. Eunice Omolo from NTV says, can we get the latest data on the fatalities and cases in childhood cancers in the country? It was quoted that we had about 3,272 in 2018. Are the numbers any better? And she's speaking towards the issue of the scarcity of data in the country. As you know, data is important because that's what determines, interventions and areas of focus when it comes to resources. And I think Sydney had mentioned it a little bit as well. So do we have the latest data, Dr. Mary? Just real quick.
Yeah, thank you, Yvonne. Again, I just want to say in the area of data, we have also made a few, let me say, steps. We have what I would call preliminary registry data. At least right now we can say we have gotten some data between 2014 to 2020 of the cancer cases that have been diagnosed in our country, which counties, what is the burden by county. So this is data that is slowly beginning to come in, and we are now beginning to be able to analyze and just see how the picture is. So it's really, let's say, in the preliminary stages. There is some kind of data that even we are using internally to be able to figure out which are the areas we need to prioritize. And what is emerging is that probably we will also need to customize our cancer control interventions specific to counties. For example, what the burden in county A might be different from the burden in county B. So again, our cancer control interventions will need to be reflect the burden in those counties. I think this is still a work in progress, but there's already something from the registry that has been established. Thank you.
All right, thanks for that. Millicent, you had your hand up. You can speak to us. I'll come to you, Prof, in a moment. Millicent.
Thank you very much. Can you hear me?
Yes, we can.
Okay, thank you very much. I would love to say that it is very important also to empower the survivors, and so that they can help the community to deliver the information in the communities. Most of the survivors, yes, they have gone through the experience, but they have not yet empowered how to deliver the message. But believe me, they know how to take care of the people going through cancer journey. And also, most of the NCDs or the cancer tests, the final tests, are very expensive. So that's why we don't have enough statistics to tell that how many people are suffering through cancer, because most of them are giving up what the final test. Maybe the person needs to do like a biopsy or a bone scan. It is very expensive here in Kenya. So most of the people just leave it like that and wait for their days to die. So it is very important to look at that. And then another thing, it is the Kenyatta National Hospital Navigation and Social Services are doing a great job on the children going through cancer, and they are really supporting and they are talking to patients and the children who are struggling. I would also ask the corporates to invest in children going through the NCDs and cancers, because it is very important. Like, for example, you can have a teenager who is a single mom, he doesn't know who is the father of the child, and immediately that child has cancer or NCD. What are we going to do about that? Will we just sit there and leave the child to die, or how are we going to help the child to get the treatment? Because I've seen such challenges, and it is very painful to see the child that the mother can't have any child because she's a minor, and then the child is struggling. So we need to see how are we going to address the issue to help the child to get the treatment. So thank you.
Thank you so much for that. Indeed, survivors would be the best advocates for that. I know we said we would finish at 11. We're 2 minutes to closing time, but because I want us to finish, can I ask everybody who's here and those on Facebook for another 10 minutes of your time, if you don't mind, just so we can wrap this up. Apologies for that, but it's really been a great informative discussion, and I want us to just finish that. So just give us 10 more minutes. Thank you for everyone on Facebook. Thank you for everyone on the Q&A. And by the way, I can see, I think Christine Sitati is responding to some of the questions that are being raised in the Q&A box. Please feel free to continue doing the same. And I urge the same of those as well in the chat box, because we can have interaction in various ways. So the final question, I think, was to you, Prof. Again, if you can, in a short while, to just answer to some of those questions that I had posed to you earlier from the plenary.
Okay, thank you very much. I think the key question was whether the new cancer therapies are available in Kenya. I'm afraid they're not. But there are ways in which we can work towards having them available. Very early in the AIDS epidemic, as new drugs came available, we got involved in research. We were involved in setting up large cohorts to do research to see whether these drugs work and how well they work in our populations. And this became actually a very important way of accessing treatment to people who are living with HIV at that point. The results of those studies helped to inform public policy, and because they had the companies or the governments who were making these drugs were more willing to even put those drugs to be made available at no cost to the participants. So my plea to the ministry is that we need to challenge our institutions like Kenya Medical Research Institute to go the way of being available for clinical trials for new cancer treatments. This will allow us to increase access to these new medications, and it will make a difference for our patients. I think as a country, to become a middle-income country, we need to move away from the mindset that we look for solutions that have been made. We need to be part of making the solutions. And in this sector, it means that not only the trials of new drugs, but also manufacturing of the commodities that are required. I don't understand why we are having to look to import commodities, for example, to ensure that we have safe blood supplies, the blood packs, the granules for giving IV drugs, all these things. We are part of the bigger East African community. It has more than 100 million people. In Kenya, if we invest, so we are not investing in just making Juakari products. We actually invest in making products that are required and are necessary in this sector. I think there's an opportunity. It will bring in great jobs. It will also make those commodities available to our population, and will actually now be performing at the level of where we are part of problem solving, not just waiting, not just going to sit there to beg please can we have this vaccine? Please can we have this? Even vaccine manufacturing is something that's possible. They do it for, we've been making the East Coast fever vaccine for our animals. I don't know why we are not investing in doing the same for our human sector. So what am I saying? That this problem, this addressing the problems we see on a day-to-day basis, but much more important is the strategic approach. Adopting a strategic approach that actually enables us to shift and to be at a different place. Thank you.
Thank you very much, Prof. Deborah, you had your hand up. I'm going to now give you, let me now enter TV speak. I'm going to give you a minute.
Yes. So first of all, I just wanted to correct Dr. Nyangasi that the pathology team is doing their best, and we are making plans to even improve our diagnostic capacity within Kisii. And so they're working with the resources that we have, and we are making plans in partnership with the Kisii University and other organizations to improve our diagnostic capacity. I would think that this session would not be complete if we do not talk about the danger signs that tell you that a child may be having cancer. So one of them, if a child keeps needing blood and appears pale and weak and easily tired, they might be having cancer. If a child has bone pain or bone swelling, that can also be a sign of cancer. If a child has abdominal swelling or has something that looks like a lump or a swelling in any part of the body, that can be a sign of cancer. If a child has bleeding, maybe like even nose bleeding or even bleeding in the skin, appearing red, that can be a sign of childhood cancer. A child having persistent headaches without fever, and sometimes even with vomiting, especially early in the morning, that can be a sign of brain tumors, and that can be a sign of cancer as well. If a child is not gaining weight well, they're just losing weight despite adequate nutrition, that can also be a sign of cancer. So cancer in children mimics very many normal infections, many normal diseases. And so one needs to have a high index of suspicion so that anytime the child keeps complaining of these problems, it's good to take it seriously and make sure that it's not cancer. And that's, we are working hard to make sure that all our cadres of staff, from the clinical officers, the nurses, and the medical officers, are now aware on how to identify. And we are working together with our teams to strengthen our diagnostic capacities so that now we are able to identify the cancer in time and start the treatment on time and follow up the patients. We also want to remember the siblings of these children. Sometimes we have children with cancer, and because the parents are so taking care of the children with cancer, they're not able to go to work. We have siblings of the children even missing school because now they have no parent to take care of them. They become vulnerable. They can, bad neighbors can do bad things to them. So we also remember that childhood cancer affects the entire family. It can even bring tension between spouses. And so we need that holistic psychosocial support for the children. Thank you.
What a wonderful way to wrap it up. I believe those signs you talked about are what have been mentioned as the index of suspicion. So thank you so much. Couldn't have found a better way to wrap it up. We have another 5 minutes to go. I want to just remind you a couple of things. I'm seeing Sydney, Benda, McLean, and a number of others, including Christine, giving their contacts, and ways you can reach them. I think to the question that was raised by Sororo, yes, there is a cancer group in Marsabit, and Kenpo is looking for ways to be able to link up with them and strengthen them and help them build the capacity that they require. Dr. Deborah, thank you. Thank you, Professor Ndwati. Thank you, Sydney. Thank you, Christine. Dr. Mary Nyangasi, thank you very much, for being here with us and for speaking about that. Millicent, thank you for reminding us, to empower survivors, and they are the best advocates, just like you are, just like Sydney is, and the many others who we know are out there. I want to say thank you to everybody who's been live with us on Facebook. Thank you to the members of the press, my colleagues in the Fourth Estate who were here, Wanjiro Boro from Kameme, Ben Kirira from K24, Robbie Chacha Omondi from K24, John Mushangi from the Star newspaper, Rosa Agutu from Radio Maisha at the Standard Group, Benjamin Yaga from Radio Africa Group, Gabriel Ingubu, who's a health journalist from Tandaza FM in Bungoma, Eunice Omolo from NTV, and so many others. And this shows you that the media is very interested in this space and very willing to work with and work with all of you in terms of raising awareness of these issues and promoting the discussions around this, so that we can play our role in having better outcomes in the treatment of and early intervention of childhood cancers, but cancer in general in the country. So, I mean, a lot of learnings here, for all of us. So, asante ni sana to everybody. In the comment section, we have another 3 minutes, so please keep chatting in there and dropping in your contacts. So we've talked about preventing now, and why this is important for the future, whether it is through vaccination or a number of the other issues that Professor Ruth Nduati had highlighted. But so where do we go from here? Benda Kithaka from Kilele Health. You can give us what happens next. Where do we go from here? Hopefully we'll have some better outcomes by the time we're commemorating this in September 2022. Benda?
Thank you, Yvonne, and thank you everyone on the call today. My name is Benda Kithaka. I'm a health advocate with Kilele Health, and we're delighted to be partners in this initiative. I have listened today, and I think all of you can echo that we've learned something new today. If you have learned something new, just use the chat box to say, yes, you've learned something new. That is one of the ways that we can start engaging now. Secondly, I've listened to all the presenters today, and when we were putting this session together, there were a few things that we hoped to achieve. So I'm hoping you can be our cross-check today to tell us whether we've achieved this. Did we increase your awareness on childhood cancers? Have you learned something new? Did we increase visibility about vaccines for cancer prevention? What role the vaccines can play in disease prevention? Did we highlight a call to action for you about HPV vaccination? If you recall, Millicent spoke about having been a 14-year-old who had a child. That was a child having a child. And that child was exposed to HPV, which is the causative agent for cervical cancer. Have we highlighted today how the HPV vaccine can actually help us in prevention of cervical cancer? Have we highlighted stories that you can take today about people who are hurting in our country? These are not just statistics. The 3,000 people mentioned, they're not just statistics. They are children who are living today affected with diseases that we can help prevent. We've had that in the West, we have up to 80% survival rate. In Kenya, we are having up to 10 to 20% survival rate. Really, is this something that's acceptable to us? Are these stories that we can get in the community for us to be able to have conversations that enlighten people about prevention? Did we have messaging today that you can take to your listeners, to your readers, to the people who follow you, so that you're able to put it together and get them to actually take action to prevent childhood cancers today? And have we listened to our government? Tell us about things that we can achieve today for the future, things that the government is setting in place as policies that can be used to improve childhood cancer prevention uptake, as well as outcomes for survivorship in this country. Do we have it within us to be able to call them to action and hold them accountable? Why I've started with questions as opposed to answers is because today we've listened a lot. And often when we are listening, we are taking notes. And often when we are taking notes, we are hoping that we can use this note to take it forward. My ask of us today is, starting now, how can we hold our government accountable to provide the necessary resources that have been mentioned so that we can cascade and escalate prevention action? Preventing today for the future means having every single girl who is eligible being able to be vaccinated today. How can we cascade that information to the community? And because we have so much media representation today, one of the beautiful things about the media is you are the voice of the people. You are the ones who people look up to for information. I wish we covered cancer, I wish we covered health as much as we did politics or any other action-oriented news as we do often in our papers, in our major media platforms. But that's not just enough. It's not just about the mainstream media. Media has been decentralized as well. We have social media, and information is being consumed very heavily. So if we have learned something today, how can we take that message as the media to amplify on the various available resources? Lastly, our communities are hurting. As a health advocate, we are in the community speaking about hope, giving messages about prevention, educating about signs and symptoms. However, it often takes the message for it to be translated into usage, for the person to go to the facility and find no services, or to find the services are delayed, or to find the consumables are not easily available, or the distances that they have to travel. So listening today, I had Dr. Nyangasi saying we have 9 facilities currently that are able to diagnose and take action on cancer, and we want to cascade this to 47 counties. Dr. Nyangasi, from the community perspective, in what timeline are we talking about the 47? I know I've seen it as a health advocate. In 5 years, these 9 centers have been able to be set up, and this is within the current strategic plan. As we are revising the strategic plan, could we look at the timeline that it's going to take for us to be able to cascade as much as possible, so that somebody in Moyale doesn't have to travel to Nairobi to seek care? Research is important, and Professor Ruth mentioned how critical it is that we translate research from bench to action that gives benefits directly to the patients that we serve. Regrettably, most of the research that we quote in Kenya comes from Western countries. We do have opportunities to research, both at primary health care, at the community, as well as at palliative care, and even at the practice of survivorship, something that's not often talked about. What can we do in all this? So this session for me was timely because we're celebrating Childhood Cancer Awareness Month. But it was also timely in that a lot of new information has been passed on by technical experts, by people with lived experiences, by people who are actively engaged in the trenches, trying to make cancer a constant dialogue in our community. My ask of the media that's represented today is 365 days from what you've had today, there is enough content to cover cancer as a subject matter and as a topic of concern for the community starting today. Let's not wait for when we hold conferences or media engagements. Let's make it our job to be inquisitive and incisive in finding these stories that encourage people to prevent, that encourage people to support children going through cancer and adults going through cancer. Let's take action to prevent. As we're preventing COVID-19 with the vaccine, HPV vaccine is also available. Let the mother who is getting the vaccine for COVID go and take her daughter who is eligible for the vaccine, so that we're doing dual prevention. Let's also advocate and be the voices of change. My ask is, when we meet next year, we will not be talking about Childhood Cancer Awareness Month. We will be saying every single day has been an awareness day for childhood cancers, and these are the milestones that we've made. We will be saying these are the policies that were touted to be being made possible. These are the policies that are being implemented now. And lastly, these are the myths and misconceptions that used to be history, because we will have demystified them. We will have brought new knowledge to the people who need to take action and to make decisions to be able to prevent. I think all of us would have a very good time next year celebrating and commemorating Childhood Cancer Awareness Month, saying that we've made exceptional strides in making sure that we improve that survivorship rate from 10% to 60 to 80 to 100%. Delighted to have you all on the call, and thank you. I think all our partner organizations have shared their contacts on the chat box, and I hope you can also share your contacts on the chat box so that we can continue this dialogue even offline. Thank you so much. Over to you, Yvonne.
Thank you so much, Benda. Great call to action. I think we're all seized of the matters you have raised. Dr. Karekezi, you started us off. It is only fair that you help us finish this.
Thank you very much, Yvonne, for a great session. Wonderful moderation. And thank you to the participants. You've been really engaged. I just want to say thank you really to our panelists for giving us your time and for sharing your expertise with us. Thank you, Dr. Mary Nyangasi. Thank you, Christy Sitati. Thank you, Dr. Deborah Omido, for giving us an overview of what is happening in the county. Thank you, Sydney, for sharing your lived experience and the work that you're doing with cancer kids. Thank you, Professor Wati. Seriously, a wealth of information. You definitely deserve the title of professor. And really, we thank you for giving us your time this morning and for giving us snippets of what is actually currently happening in the world in the line of cancer treatments and other areas of research that we actually need to focus on as we move forward. Last but not least, thank you, Millicent, for sharing your story with us and for the work that you're doing in the community to just advocate for treatment, for vaccines, for girls, and for other cancer survivors that you're working with. Thank you for your commitment to do that. Before I finish, I want to thank all our participants for joining us this morning. Thank you for giving us your time and even for your commitment. We look forward to working with you as we move forward. We look forward to as we move forward, and as Benda has said, every day should be a day where we remember childhood cancer. And we look forward to hosting you again, even in our other forums when we talk about the other non-communicable diseases. And last but not least, thank you, Yvonne, for giving us your time. It has been a beautiful session, wonderful session. And I mean, beyond our expectations. Seriously, we've really had a great time. We've learned a lot. I personally have learned a lot. Many things that I didn't know about childhood cancer, but every day is a learning experience. And we thank you for giving us your time. So on behalf of NCD Alliance, I want to thank everybody for joining us this morning. We look forward to continued engagement and also moving the NCD agenda forward, ensuring that no one is left behind and holding the government to account for the commitments that it has made. We will be releasing a press statement, which we had hoped to have before this session. It will be out in a short while. So if you can give us your email contacts, we'll definitely send it out to you. But yeah, thank you, keep safe, and God bless, and look forward to meeting you next time. Thank you very much.
Thank you, Dr. Karekezi. And just a quick one, Benda, maybe this one might be to you. We've got Anne McKee and I think Ben Kirira asking for a recording of the session. I think with a lot that's been said here, just in case anybody has missed something, might be they want to go back for reference. And I think some of their email addresses are dropping. So I'm just giving you, oh, and then there is, and thank you for this, Caroline Mati, perhaps have a sign language interpreter next time. Yes, very important. Thank you for that reminder, and we'll continue to make all of these sessions better. So we thank you for your feedback on that. Asanteni sana, everybody. Gosh, I wish we could talk about this a lot more, but thank you, all of you. Thank you, panelists. Thank you, participants, for making the time here. I'm giving you like 2 more seconds to drop your email addresses in the chat box, but all of that will definitely be available to the organizers and the panelists. Thank you very much. Have a great day. And let's go out there and be ambassadors, prevent now for the future. Thank you very much. Have a good day and God bless you.